So now I'm going to hand over to Dr. Chris Manu. Thank you, Chris.
Many thanks, Joan and the Diabetes Africa for this opportunity to share my experience in people with diabetic foot disease. So as per, we will try and talk about the diabetic foot and try and generalize or simplify as much as possible for the whole spectrum of people who might be involved with diabetes care. So with regards to, just as an overview, maybe over the next half an hour or so, we'll try and have a bit of a discussion around what is diabetic foot and what does it look like in people with dark skin compared to people with light compression. What are the causes of a diabetic foot, and what are the rates of diabetic foot in people with diabetes, and what are the typical tips or things to avoid, or the caveats to deal with the diabetic foot, and the do's and don'ts regarding this pathology. So in general, I think we all hear big figures that we always worry about, that nearly 500 million of adults are living with diabetes at present, according to the IDF data, and three in four with diabetes are living in areas with low and middle income countries. Diabetes, we know, is going to cause cardiovascular disease, kidney disease, or sometimes diabetic neuropathy, or eye disease, diabetic retinopathy. It can cause pregnancy complications and nerve disease in diabetic neuropathy. So in essence, anywhere that blood can go, diabetes can cause complication in that organ or that tissue. In particularly when we talk about the diabetic foot complication is one of the most common and most costly severe complications of diabetes. When we talk about the diabetic foot or damage in the diabetic foot, it's important to picture it as any tissue in the foot. So sometimes people think about diabetic foot complications just being an ulcer or a wound on the foot. But it's important to know that all the tissues in the foot can be affected. So it can be the bones, it can be the blood vessels, it can be the tendons, it can be the nerves, or it can be the skin, or when there's a skin breakdown. As you can see here in this picture, that this patient's heel has gone complete discoloration there, and clearly there is some tissue damage there, although it might not be seen obviously as an ulcer or a wound. And again, in the picture on the right hand side, you can tell that this left foot is much more swollen compared to the other foot. And that gives an impression that there must be something wrong with the bones. So when we talk about a diabetic foot, that is sort of the idea that needs to be had, not just ulcers. And then the question can be asked, what causes the diabetic foot? It's important to think about it like a triad, or like when you say the causes of fire, needing fuel, or air, and so on. In the diabetic foot, three main pathologies come together to cause this complication. So the damage to the nerves in the foot, which is the neuropathy. So people lose their feeling in their foot. And then you've got the vasculopathy, or damage to the blood vessels in the foot. So again, similar to having like thick fluid or oil down your sink that can cause the sink to block, the high blood sugars can damage the blood vessels in the foot, so causing poor vascular supply or vasculopathy. The third aspect that comes together, which is the immunopathy, or the poor immune system, or the increased risk of infection. Bacteria like sugar, and wherever there's sugar, there's high risk of infections. So all these three aspects come together to lead up to this, what we call that the diabetic foot or diabetic foot complications. And we'll try and go through perhaps each aspect of this triad, break it down and see how it can slightly differ, or why it leads up to the diabetic foot.
And Chris, you've given us so much information there already. Could you go back to that previous slide as well?
The one that we did a triad.
The one before. So you've given us so much information. I mean, it's fantastic what you've packed in already. And, for us as healthcare professionals, you've given us that fantastic analogy and visual description of that triad of things that can cause people with diabetes, living with diabetes, to have a problem with their feet. So for a person living with diabetes, just as an example, on the left-hand side, that heel and that area, could you give us an idea what sort of things might the person have experienced to have that lesion on their heel? And also, would it have appeared like that at the beginning, or has that developed over a period of time?
Yeah, so if perhaps I go on onto it, this is the cornerstone of all the problem. That what can start as a small, let's say, hairline or a crack on the heel or a small blister or a small shoe rub can go undetected because the person has lost the feeling in the foot. So for someone without diabetes, if you wear shoes that are slightly tight, it becomes painful. You limp, you take the shoe off, you check it, or you take the shoe off and, wear different shoes because you can feel it. But the problem with people with diabetes is that they have lost that feeling because the diabetes has damaged those nerves. So that's how sometimes it's the patients themselves cannot tell how long the problem has been there for. We've had patients who have come to hospital and you take the shoes off and there is a nail that has gone through their shoe, but they've been wearing it. So the honest answer is that most of the time, and from a survey that was done across Europe as well, about 60% of patients were not aware of when actually the problem started, from the start of the problem. Then the other aspects do come into play in terms of how rapidly does it deteriorate. When the blood sugars are high and not enough blood is getting to that area, that small crack on the heel can then get infected. And then when it gets infected, it can spread like wildfire. And I've sort of deviated from this talk. I will not talk about sort of the diabetic foot attack, but sometimes it has been referred to as a foot attack because when you have that crack there, infection sets in, the tissue dies, then it can spread very quickly. And we can talk hours to sometimes days. So that rapid deterioration can then depend on the patient's comorbidities. They've got heart problems, they've got kidney problems. All of that can then dictate how rapidly it accelerates when the infection sets in.
And I love your analogy of the triad because also for me as a healthcare professional, being in a consulting room, consulting with somebody living with diabetes, as you said, what people see at the surface, so it's almost like a pyramid. So what people see at the surface doesn't show what's going on underneath the surface. And it's almost like you've got that pinnacle, which is the bit at the top you can just see at the surface. But there's huge amounts of immunology going on, underneath the surface, if I can put it like that. So love the analogy of the triad because it's so relevant, so many aspects of diabetes and diabetes foot. And just to go back to that previous slide, I'm sorry, Chris, but these slides are packed full of so much information. People may not have realized when you look at that left foot on the right-hand side of the photo, you'll notice that there's only four toes. So that person's had a problem with their feet already. And I know you're going to bring this forward to people's attention. Once you've had a problem with your feet, the risk of you having and further problems with your feet is increased. As I say, Chris, so much information. Thank you so much.
Yeah. And John, again, to elaborate on that, again, time may not allow us in the end and we might be rushing at the end, but that's why it's important to realize that about the bones. And as you rightly pointed out, once you lose a toe, I mean, not to digress too much, they say there's one of the propositions solved made is there's nothing minor about minor amputation. So in this case, you might think that the patient has just lost one toe. But as soon as you lose one toe, the whole architecture of the foot changes. And then you have pressure on the bones within the foot as well. So that's why the mechanism of the foot then changes completely and you can have damage to the bones itself in the foot. So that's why the foot can become swollen like that. and a condition sometimes called shark of foot, or sort of like a damage to the bones. So as you rightly said, sometimes the whole skin could be intact and might think that, okay, there's nothing wrong with the foot. The patient will not feel any pain, but the bones underneath could be crumbling. And I think I've got some x-rays further on that shows that, as you rightly said, that there could still be significant damage going on underneath, which both the patient and sometimes even the clinician will still miss, because the patient will not complain about any pain in the foot. And if they come to the doctor and say, "I have any problem with your foot?" they will say no, because they cannot feel any problem. They cannot feel any pain. If they go to A&E, their foot might be swollen, but because they are not in pain, they will not get an x-ray, because they do not complain about pain in the foot. So again, that's why the triad of that neuropathy comes in. That's what leads people into getting into problem, because when the pain is not there, then the clinicians are less likely to investigate or do anything further.
Thank you, Chris.
Yeah. So sort of moving on. I mean, with regards to the prevalence, also of how big this is a problem. So about up to sort of 25% of people with diabetes will develop an ulcer during their lifetime. This is just ulceration. And as I said, it can be ulcers, it can be bone damage. So this is just ulceration. So again, if you think about the population of Africa or, developing countries, this is going to be like a tsunami. And I'll come on some other slides again. With regards to the annual risk, so someone, in terms of if you've got a practice, you expect about 5% of that population to develop diabetes, within foot problem or ulceration within that year. With regards to the prevalence, is again reported up to around 12% of the population have got diabetes, foot ulcers in most reported studies. And the quite threatening, I know most of the time people talk about the amputation much more, but people with diabetes are up to 25 times more likely to end up, losing a part of their foot or leg because of diabetes complications. So it is not a benign condition as it might sound, that it's a silent killer, so to say. And then on this slide here, on the right side of the slide is just some data from the US. So diabetes, one of the people who develop diabetes and foot problem, first of all, the thing to point out is got associated with very, very high mortality. So a very, very high 5-year mortality, which is worse than most cancers. And I think we all hear branded round about how bad cancer is, and we are almost all quite fearful about getting cancer, or if a family member has got cancer, almost the whole family gets to know of it. And there's so much sympathy. Oh, uncle this or auntie this have got cancer. But when someone develops diabetic foot ulcer, it doesn't carry that same sort of urgency or need for action. So in this year, this is a 5-year mortality. So it's someone with a breast cancer, there is around 10%. So about 10%, or 10 out of 100 of them will die within 5 years. If someone with diabetes developed the bone damage that I was describing, the shark of foot, then it's got a 5-year mortality of nearly 30%. If they develop a foot ulcer, again, it's nearly 30%. If you look at the mortality for all cancers, it's about the same, around 30% as well. If someone with diabetes develops an amputation, so a minor amputation, so missing just one toe, the mortality is going up to nearly 40%. So that's 4 out of 10 of these patients are going to die within 5 years. If they have ischemia or poor blood flow to the legs, again, it's going to around 55, nearly 60%. Nearly 6 out of 10 of them will be dead in 5 years. When they get a major amputation, so having their leg taken off, either below the knee or just above the knee, or basically any amputation above the ankle, is associated with a 5-year mortality of nearly 60%. So it is, and this is the US data. And in Africa and developing countries, the data is much more positive of data. but it will definitely be much higher as we collect more data. So this is US, also of developed countries. And this is how bad the data is looking there. So that's why with what is going on in Africa or developing countries, again, I repeat, it's going to be like a tsunami when these complications start happening and the mortality associated with it.
Can we stop there, Chris? Because I just think that is such a startling, shocking statistic for people to become aware of. When I first saw this slide, not broken down in terms of the degree or the type of foot problem that there was, it was for overall diabetic foot related problems. I was astonished. For me as a healthcare professional, I was absolutely astonished and shocked and saddened that the mortality for somebody living with diabetes who has a foot problem was greater than it was for somebody who had breast cancer. And, quite rightly, we put a lot of effort into making people aware of how they should look for signs and symptoms of breast cancer, that early treatment, all the treatments that are available, quite rightly. But our awareness of diabetic related foot problems is just not even on the scale compared to breast cancer. Yet the mortality is so much greater. And I think, people are going to be shocked to see this information. If a toe is removed, that is signaling that your mortality is greater than it would be for if you had breast cancer. And people would think that's, and I hate to say this, a minor problem. It is in no way, in no respect, a minor problem. And again, we come back to that triad. It's mirroring what's going on in the rest of your body. So if you're having problems in your feet because of either the nerves or the blood vessels being affected, this is mirroring other parts of your body having those same problems as well. It's just startling, Chris. It really is. And, this is in a high income country as well. And as you quite rightly point out, for low and middle income countries, it's likely that the mortality is going to be, we can't say definitely, but it could be worse. It could be worse. It's just so shocking, Chris. It's just so shocking. Yeah.
And, in terms of the data that is there, there's a systematic review published by Rigato et al. In 2018. And it was a study of nearly, I think, about 55 or 50 something publications that from various areas in Africa, which showed that the prevalence of foot ulcers were around 13%. In the UK, it's around 2.5%. So it already shows you how the prevalence does differ, although these are not from research publications and systematic review. And approximately 15% of patients with foot lesions underwent major amputation. 15%. In the UK, it's 1.7% of patients. In the UK, we do the National Diabetes Foot Care Audit, and 1.7% of patients who presented with foot ulcer underwent major amputation. But in this systematic review, it's 15%. So again, it tells you how high this mortality is going to be. If in the UK it's 1.7% having amputation, whereas in this review it was 15%, and most patients, 14% died during their hospitalization. So it's a condition that I cannot repeat it enough, that people suffer in silence, or because they do not have the pain. They do not have the pain like a heart attack pain. They do not have the sort of vivid symptoms like the stroke or the cancers and so on. But people are literally dying in silence.
And Chris, we're talking about mortality, and I know you're going to talk about signs and symptoms, give us tips. And I think one of the other things that was very striking to me always is how miserable it can make life. how the impact it can have on people's lives. So even, before mortality, if I can put it like that, it can disrupt your work, it can disrupt your social life, it can disrupt your day-to-day life, your family life. Things like driving become difficult. It has so many implications. And I'm going to come back to that word that we've used a lot during this series of webinars: prevention. Awareness. We need awareness, we need knowledge, we need empowerment, and we need prevention. We absolutely need prevention.